Assalamu alaikum everybody. My name is Abdullah Salim Elhwuegi. Welcome back to my Principle of Pharmacology. This is a continuation of drugs acting on the central nervous system. In this presentation, inshallah, we are going to discuss an important group of drugs which are local anesthetics. As we have said before, anesthesia means loss of pain sensation. If this loss of pain sensation is accompanied by loss of consciousness, this is known as general anesthesia. And we have talked about the general anesthetics, whether they are inhalation anesthetics, which are given through the respiratory tract, or intravenous general anesthetics, which are given through the intravenous route. When the loss of pain sensation is not accompanied by loss of consciousness, i.e. the patient will remain conscious. In this case, this is known as local anesthesia. If local anesthesia is limited to specific area in the body, this is known as local anesthesia. If it involves larger area of the body, in this case, it is known as regional anesthesia. Therefore, local anesthesia, usually it is very limited to specific small area in the body, while the regional anesthesia involves larger or specific parts of the body. But the drugs which are used in both cases, drugs which are used to produce local anesthesia or regional anesthesia, they are the same. They are the same group, and generally they are known as local anesthetics. So what are the main objectives of this presentation? What we are looking for? What we would learn at the end of this presentation. We will understand what are the different groups which are used as local or regional anesthetics. We are going to discuss the structure-activity relationship and how the structure will affect the pharmacokinetic and the pharmacodynamic property of the local anesthetic. We are going to discuss as well their mechanism of action and how they produce the loss of pain sensation. We are going to discuss their pharmacological actions and what are the factors which will affect their pharmacological activity, and as well we will discuss their toxicity. Finally, we'll discuss how they are given, what are the different methods of administration, and their clinical application. I hope that you enjoy this lecture with me, and we start when we use these drugs. What are the clinical conditions of using these drugs? Usually these drugs are used in minor surgeries, as we will see later inshallah. Also, they are used in patients who are at high risk of side effects related to general anesthesia, as we have discussed before. There are patients who cannot be given the general anesthetics. Also, they are used when the patient try to avoid loss of consciousness. Some patients, they refuse to receive the general anesthetics. So in this case, we use the alternatives, which are the local anesthetics. They don't produce loss of consciousness. Also, they are used in ambulatory surgery. Ambulatory surgery means fast discharge of the patient from the hospital after recovery, and usually the recovery is fast. So these are the general uses of these drugs. So what are the chemical structures? As we have said, that chemical structure will affect the pharmacokinetic and the pharmacodynamic property. So first we will discuss the chemical structures of the local anesthetics. Most of the local anesthetics, they are formed from three parts. From an aromatic group, which is usually a benzene ring. It can be any other aromatic group, like in most of them, it is a benzene ring. This benzene ring is linked to an intermediate linkage. This intermediate linkage, it is either an ester, as you can see here, an ester linkage, or it is an amide linkage. So it is an aromatic group linked to intermediate linkage, which is either an ester or amide linkage. A terminal group is a tertiary amine, as you can see, tertiary amine group, tertiary amine group. So these are the three main parts of any local anesthetics. They differ, of course, in the substitution, in the intermediate linkage, and as well in the aromatic group. The aromatic group, usually this will determine lipid solubility. As we know all that aromatic groups, usually they are lipid soluble, they are lipophilic. Therefore, they will determine the lipid solubility of the general anesthetic. The intermediate linkage will determine what's known as site of metabolism, because as we know that the ether, usually they are metabolized by plasma cholinesterases. Therefore, they will have a short duration of action. Why? Because they are metabolized by plasma cholinesterases. Once they enter the bloodstream, they will be metabolized by plasma cholinesterases, pseudocholinesterases. The amide group, on the other hand, it is metabolized in the liver. They metabolized in the liver. Therefore, we will expect that the amide group, they will have a longer duration of action. Therefore, the ester groups will have a short duration of action, while the amide groups, they will have a longer duration of action. The tertiary amine group will determine lipid solubility. As we know that the tertiary amine is ionizable. It can be ionized in biological fluid, it can receive a proton, and it become ionized. When it is a tertiary amine, it is lipid soluble. It does not carry a charge. It can pass the biological membrane. ولكن if this tertiary amine is present in acidic media, it can receive a proton and it will become ionized. It will become ionized. In this case, it will become quaternary amine. Quaternary amine. Quaternary amine, usually they are non-lipid soluble. They are non-lipid soluble. Yani they cannot penetrate the biological membrane. So anybody, when he asks you which part of the local anesthetic can enter the biological brain, is the non-ionized tertiary amine. Okay, so these are the main structure of local anesthetics which are in clinical use nowadays. So what are the amide? The first group, I said they are amino, because this amino relates to the tertiary amine. Amide with an amide linkage in the intermediate chain. These amide local anesthetics, we have very examples like lidocaine. This is the American or USA name, North American name. While lignocaine, this is used in British Isles, in England and Britain in general. Okay, the commercial drug is xylocaine. So lidocaine, very famous. We never forget, because it is a local anesthetic, and as well it is anti-arrhythmic. It is used in treatment of certain types of arrhythmia. A second example is bupivacaine. This is very famous. It is long-acting. It has a long amide chain, and it has a long-acting activity. Third example is mepivacaine. And lastly, levobupivacaine. Levobupivacaine, as you can see, it is not a racemic mixture. The others, they all racemic mixtures. They are from the dextro and levo forms. Levobupivacaine, it is the levo form of the bupivacaine, and it has a more selective activity in blocking sodium channels. Okay, so these are examples of the amide local anesthetics. The ester local anesthetics includes the most famous cocaine اللي كوكايين اللي معروف بالكوكايين. Cocaine, as we all know, it is a natural. It is obtained from coca leaf. It is natural alkaloid, cocaine. Cocaine, as you will see, it differs from other local anesthetics. Cocaine, they made a chemical change in the structure of cocaine, and they produced procaine. Procaine was the first ester which is introduced into clinical medicine. This was followed by chlorobrocaine, tetracaine, which is known as amethocaine in England, in British Isles. And lastly, benzocaine. These are all are esters. As we have said, the esters usually they are metabolized in the blood by pseudocholinesterases, by plasma esterases. Therefore, they will have a shorter duration than the amide local anesthetics, which are metabolized in the liver. Therefore, they will have a longer duration of action. Lastly is articaine. Articaine, this is very characteristic local anesthetic, is different from the others because it is not a benzene ring, it is a thiobenton ring with an ester linkage and amide linkage in the same molecule. So it has an ester linkage and amide linkage. So articaine is the only example of ester amide local anesthetic. So it is metabolized in the liver and as well it is metabolized by plasma esterases. So articaine is the only example. Articaine is the only example of local anesthetic with ester and an amide linkage. That means it is metabolized by the liver and as well it is metabolized in the plasma by plasma esterases. Okay? So these are the chemical structure of the local anesthetic and how it can affect both pharmacodynamic and pharmacokinetic properties. Now we'll talk about the mechanism of action, how these drugs they produce their action, how they produce loss of pain sensation. This information has been obtained from this reference. If you want more information, you can go, this is the Dewey number of the article. You can go to this article and you can see the details in that article. So what will happen? As we know, in all pain sensation, they are transferred from the periphery to the afferent sensory nerve fibers through the spinal cord and up to the sensory cortex, as we have discussed before several times. So any pain sensation will cross from the periphery through the afferent nerve fibers up to the cortex, sensory cortex, where sensation takes place. So what the local anesthetic logically, what they will do, they will block this conduction of the sensation somewhere where they are given. So they block the conduction of sensation in certain parts of the afferent nerve fibers, and therefore pain will not be transmitted towards the central nervous system. So as we know, an pain sensation will travel through the nerve by opening of certain sodium channels. As we know, the nerve contains what's known as voltage-gated sodium channels. Voltage-gated sodium channels. These voltage-gated sodium channels usually they are closed in resting stage when there is no sensation carried out through the nerve. In this case, sodium channels will be in closed state. Okay, this is known as resting or closed state. When pain is transferred, when action potential is generated in the nerve, they will cause opening of sodium channels. That's why they are known as voltage gated. That means because of change in the voltage of the membrane, sodium will open. Once sodium will open, sodium will rush into the nerve terminal, and in this case يحصل reversal of polarity. So the positively charged ion will be inside and the negatively charged ion will be outside. This is known as depolarization, as we have discussed several times before. Okay, so now this depolarization will take place and the activity will be transmitted along the nerve fiber towards the cerebral cortex, okay, towards the sensory area and the cerebral cortex. Okay, this is the normal physiological activity, how pain is transmitted. ولكن in presence of a local anesthetic, what will happen? As we have said, the local anesthetic, it is present in two forms, non-ionized tertiary amine form. This non-ionized tertiary amine form, as we have said, it is lipophilic, it is lipid soluble, therefore it will penetrate the biological membrane by passive diffusion, as we have said before. And this penetration inside the cytoplasm, this is the outside of the neuron, this is the neuronal membrane, and this is inside in the cytoplasm. In the cytoplasm, the local anesthetic molecule, will be ionized. Why? Because the cytoplasm is partially acidic. Cytoplasm pH is lower than outside the extracellular fluid. So intracellular cytoplasm, usually they are slightly acidic. So what will happen to the local anesthetic molecule? It will be ionized. Once it is ionized, it will be converted to a form that it can block a sodium channel. It can enter and block a sodium channel. It will block only the activated open sodium channel. It will block the activated sodium channel. If the sodium channels that are closed, in this case, they are in resting position, the local anesthetic cannot block it because already the receptor is blocked. But when the sodium channels, they are in active state, they are open, in this case local anesthetic can block the sodium channel. This is very good advantage because it means that the local anesthetic will block only the activated sodium channels. It will not affect the sodium channels when they are in resting stage. This blocking of activated sodium channel is known as use-dependent or phasic block. So if somebody asks you what does it mean, use-dependent or phasic block, it means that the local anesthetic, the ionized local anesthetic molecule, will block the active sodium channels. If it is inactive, it cannot block it, okay? And this is an advantage of the local anesthetics. So this is the mechanism of actions of the local anesthetics. What they do, I repeat it again, they block conduction through the afferent nerve fibers. طبعا they block other nerve fibers as we will see later. They block the conduction through the afferent nerve fiber, therefore they block the sensation. How they do that? They do that by entering into the cytoplasm in non-ionized form, which is a lipid-soluble form, and inside the cytoplasm they receive a proton and they become a quaternary amine ionized. This is the form which can block sodium channel, and they will block only the activated sodium channel, and this is we called it use-dependent or phasic block. Any more further information you can get it from this reference. Okay, so these are the mechanisms of action of local anesthetics. They block sodium channels. Okay, of course, the blocking of sodium channels, some of them they are selective or some of them they are non-selective. Yani they can block the sodium channel, for example, in the neuron, and as well they can block sodium channels in the heart, for example. Okay, so next we'll discuss the sensitivity of nerve fibers to the local anesthetics. Do all nerve fibers they have the same sensitivity to the local anesthetic, or they have different sensitivity? Of course, they will have different sensitivity, as we will see. This sensitivity will depend on two factors: the size of the nerve fiber and whether the nerve fiber is myelinated or non-myelinated. As we know, the fibers they might be non-myelinated, i.e. their axon is not covered by a myelin sheet, or they might be covered by a myelin sheet. In this case, they are known as myelination. So the degree of sensitivity will depend on the size of the nerve fiber and as well on its myelination. So the order of block, the small nerve fibers first, they will be anesthetized first before the large nerve fibers. And this is logic, this is expected, because usually the small nerve fibers, they need a smaller amount of the local anesthetic to be anesthetized. This is logic. Of course, larger nerve fibers, they will need a larger amount of the local anesthetic. So sensitivity of the small nerve fibers will be first. A second factor which will determine the order of sensitivity is the myelination of the nerve fiber. As we know, in the nerve fiber, some of the nerve fibers, their axon is covered by a myelin sheet, which is produced, as we have said before, by certain glial cells. This myelination, in this case, the transfer of action potential through this type of fiber will be conducted fast. Why? Because the action potential does not go through the whole axon, but jumps from one node of Ranvier to the other node of Ranvier. It jumps like that. So transfer of the action potential to the myelinated nerve fiber is fast, very fast. It is faster than the non-myelinated. Non-myelinated, the action potential has to cross the whole axon from the beginning to the end. Like in the myelinated nerve fiber, the action potential can jump from one, this is known as node of Ranvier. Node of Ranvier. This is node of Ranvier. It can be jumped from one node of Ranvier to the next. Therefore, in this case, all we have to do is to anesthetize the node of Ranvier. That means the myelinated sheet will need a smaller amount of the local anesthetic to be anesthetized. Therefore, the myelinated sheet will be anesthetized before the non-myelinated sheet. Okay? So somebody might ask you why the myelinated nerve fibers, they are more sensitive to the local anesthetic than the non-myelinated. Why? Because we need the smaller amount, because in this case all we have to anesthetize is the nodes of Ranvier, and this case we block the conduction of action potential. So in this case what we expect in the small myelinated nerve fibers will be the first to be anesthetized. This will be followed by small unmyelinated, because we have said first is the size, then the myelination. So if it is small or myelinated, in that case it will be anesthetized first. Then the small unmyelinated, followed by the large myelinated, then the large unmyelinated. Okay? So this is the order of sensitivity. Small myelinated at the beginning and the large unmyelinated at the end. If we just go further into further detail in this, we know that the nerve fibers in the body, they are formed from three different types. The first is known as the A fibers, which are usually myelinated, and there are four different types of A fibers, as we will discuss now in details in a few minutes. The second type is the B fibers, which are usually myelinated, and these will form the autonomic preganglionic nerve fibers, which are relatively intermediate in size. The other is C fibers, which are non-myelinated, and this is the smallest fiber. And the C fibers usually they are responsible for the conduction, slow conduction of sensory impulses. They conduct dull pain from the skin and viscera. They conduct dull pain from the skin and viscera. As I have said, the A fibers, there are four different types. The largest is the A alpha fiber. Well, A alpha fibers usually they conduct sensation from the skeletal muscles. Next will be the A beta fibers, which are responsible for conduction of touch sensation. A gamma fibers, which are relatively smaller, and they conduct conduction to the muscle spindle. And lastly, the A delta fiber, which are responsible for conduction of nociception, pain sensation, and cold sensation from different parts of the body, including skin, muscle, bone, joints, and viscera. So mostly pain sensation is conducted through the A delta fibers. Okay. So the order of loss of sensation occurs first, because as we see here, pain is conducted through the smallest, A delta fiber. So loss of sensation occurs first in the pain fibers, followed by the temperature, followed by the touch, and lastly the pressure. So loss of sensation occurs in the order of pain, temperature, touch, and pressure. Okay? So all we have to know in the sensitivity of nerve fibers are different from one type to the other, and this difference in sensitivity is controlled by size and myelination. As we can see here, A alpha fibers, they are the largest in size, therefore the conduction in them will be slow, followed by the A beta fibers, A gamma fibers, and the most sensitive will be the C fibers, because they are the smallest in size. Okay? This is the sensitivity of the nerve fibers. So each nerve, it has on its sensitivity according to its size and its degree of myelination. So we have said in local anesthetics, they produce local anesthesia, loss of pain sensation by blocking of sodium channel in nerve fibers, and the nerve fibers are have different sensitivity to the local anesthetic, depends on their size and their myelination. Okay. Now we'll talk about the pharmacological actions of the local anesthetics. All the local anesthetics, they have qualitatively the same pharmacological action except for cocaine. Except for cocaine. They differ, as we will see later. They differ quantitatively in their onset of action, in their duration of action, and in their potency. Qualitatively, they had the same pharmacological action, as you will see, either whether it is a therapeutic action or side effect. ولكن quantitatively, they differ in three major things, very important things, which differentiate one local anesthetic from the other. They differ in their onset of action, معناها the time between the administration and observation of the local anesthesia, onset of action. Some of them, they have fast onset. Some of them, they have slow onset. They differ in their duration of action. Some of them, they have a longer duration. Some of them, they have intermediate or short duration. وهكذا. They differ as well in potency, in the amount of the anesthetic required to produce local anesthesia. These three factors is determined by the state of ionization of the local anesthetic. As we have said, the molecule of the local anesthetic is present in two forms, either in tertiary amine form, which is lipid soluble, lipophilic, and we need that to penetrate into the cytoplasm, and the ionized quaternary amine, and we need that form to block sodium channel. So this will determine the onset of action, the duration of action, and the potency. We expect that, therefore, if the molecule is present is non-ionized, that means it can penetrate into the biological membrane faster, and it will have a faster duration of action. Once inside, if it is inside the cytoplasm, if it is ionized in larger amount, that means it will produce a longer duration of action and produce high potency. Okay? So all the local anesthetics, different local anesthetics, they differ quantitatively in three things: onset of action, the duration of action, and the potency. What are the factors which will determine these differences? What are the factors which will determine these differences? The first factor is the drug pKa. The drug pKa, as we have discussed before. The drug pKa, when we talked about the principles of pharmacokinetic, we said it is the pH at which 50% of the drug will be ionized and the other 50 will be non-ionized. This is known as the pKa of the drug. pKa of the drug is the pH at which half of the drug will be ionized and half of the drug will be non-ionized. Therefore, we'll expect, because the local anesthetic is an amine, we'll expect the lower the pKa, the higher the percentage of the non-ionized part. Therefore, the higher the percentage, that means the faster the entry into the neuron, and therefore the faster the onset of action. I will repeat that. So we have said that the drug pKa is the pH at which half of the drug will be non-ionized and the other half will be ionized. Therefore, we will expect that the lower the pKa, the higher the non-ionized fraction of the drug. Therefore, the faster will be the entry into the neuron, and therefore the fastest is the action. The onset of action will be fast. Therefore, the lower the pKa, the more the non-ionized fraction, and therefore the faster is the onset. For example, if we take an example, if I say drug A has a pKa value of, say, for example, 7.9, and the other drug B, it has a pKa value of 8.2. Which one you think will have a faster onset of action? Which one? A drug ولا B drug? Tell me, which one will have a faster? Well, first we have to look at the pKa, which is the smallest. 7.9 is smallest than 8.2. That means drug A will be mostly present as non-ionized at biological pH. Therefore, it can penetrate the membrane, the neuronal membrane faster, and it will produce fast onset. Okay, so A will produce faster onset than drug B. Okay, yep, this is the first important factor, the pKa value. And the pKa قلنا it is the pH at which half of molecules will be ionized. In our case, in this is an amine. Therefore, the lower the pKa, the faster the entry into the neuron. Okay. Next factor is the biological pH. Biological pH. pH, as we have said, the molecule, if it is present in acidic media, in this case, it will be ionized. If it is unionized, in this case, it cannot penetrate the biological membrane. So, in this case, if the pH of the physiological solution is acidic, the local anesthetic cannot penetrate. Therefore, the onset will be slow in onset. زي ما يحصل في حالة الانفكشن. As in case of infection, people who have infection around the tooth, when he goes to the dentist, he will ask him to take antibiotics to remove the infection first, because in an infection it is an acidic media. Acidic معناها when we inject the local anesthetic, it will be in acidic media, it will be mostly ionized, it cannot penetrate into the biological membrane, into neuronal membrane, it cannot produce anesthesia. Okay, so the pH of physiological solution is essential for the crossing of biological membrane. If it is acidic, the local anesthetic will be protonized, it will be ionized, it cannot penetrate the biological membrane. This is one. A second, as we have said, the blocking of sodium channel will depend on the ionized fraction of the local anesthetic. Therefore, the inside, the cytoplasm, should be slightly acidic for the local anesthetic to produce action. Why? Because in this case, only the ionized fraction can block the sodium channel. Okay? A third factor which will determine the difference between the local anesthetics is the protein binding. The protein binding. We'll expect in the protein binding, the more the protein binding, the more of the local anesthetic will be stored. Therefore, the protein binding will release the drug slowly, and this will result in increasing the duration of action of the local anesthetic. Okay? So, protein binding, the higher the protein binding, the longer is the duration of action. Because in this case, the protein binding will act as a store, which will store the local anesthetic molecule, and it will be released slowly, and therefore will increase the duration of action. The fourth important factor is the blood supply, to the area of injection. As we have said, they are known as local anesthetic, local. That means we need a local action. If therefore there is a high blood supply, in this case what will happen? بيحصل absorption of the local anesthetic to the general circulation and distribution to other parts of the body. لكن if the blood supply is low, that means no distribution, that means the local anesthetic will stay in its place of administration, that means prolonged duration of action. Okay, so the higher the blood supply, the shorter the duration of action. The lower the blood supply, the longer the duration of action. Okay. Last factor which we will discuss is the length of the intermediate chain. If the intermediate chain linking the benzene ring to the peripheral amino group is long, the duration of action will become long and the potency will become higher. So increasing the length of the intermediate chain, increasing the length of the intermediate chain will increase the duration of action and the potency of the local anesthetic. And the most famous example is bupivacaine. Bupivacaine, it has a long intermediate chain. That's why it is about 4 to 5 times more potent than lidocaine. Bupivacaine is the most potent local anesthetic. Somebody would ask you why. Bupivacaine is the most potent local anesthetic. Why? Because it has a longer intermediate chain than other local anesthetic. Okay, so this is the pharmacological actions. We have said quantitatively the different the onset of action, duration of action, and potency. Qualitatively, they have the same actions together. So what are the factors which determine their difference? First, drug pKa. We have said the lower the pKa, the more the non-ionized, and therefore the faster the onset. Okay. The second is the pH. Second is the pH of physiological solution. We said if it is acidic, that means ionization of the molecule. The ionized part is needed for blocking of sodium channels. The non-ionized is needed to cross the biological membrane. Protein binding will act as a store, therefore will increase the duration of action. Blood supply, increasing the blood supply means more distribution, that means shorter duration of action, and vice versa. Increasing the length of the intermediate chain will increase the duration and potency. And the most famous example is bupivacaine. Bupivacaine, it is the most potent local anesthetic. Okay, we said that all local anesthetics, they have exactly the same qualitative pharmacological action, except for cocaine. Cocaine is different from other local anesthetics. So other local anesthetics, all of them, they share exactly the same property, except in their onset, in their duration, and in their potency. The cocaine is different. Why it is different? لأن الcocaine, it is natural. It is CNS stimulant. It's not a depressant. Cocaine, as we know, الcocaine معروف الcocaine. It is CNS stimulant, وكذلك it is a drug of abuse. It is abused. Why it is abused? Because the cocaine, by reducing CNS stimulation, can produce certain types of euphoria, and this will produce what's known as psychological dependence, as we will discuss inshallah next lecture. Also, cocaine is different from the other local anesthetic. It acts as indirectly acting sympathomimetic, i.e. they increase the sympathetic activity indirectly by inhibiting their uptake into the adrenergic nerve terminal, as we have explained before. That case, معناها if they act like adrenaline or noradrenaline, what they will produce on blood vessel, will produce vasoconstriction. As we will see, other local anesthetics produce vasodilatation. Others. If anybody asks you which is the local anesthetic which produces vasoconstriction, the only example is cocaine. The only example which produces vasoconstriction. If somebody asks you why cocaine produces vasoconstriction, because it acts as indirectly sympathomimetic. It inhibits the reuptake of adrenaline into the adrenergic nerve terminal. Adrenaline and noradrenaline, of course. Okay? يبدأ they produce vasoconstriction. Madam, vasoconstriction, what you expect will happen to the blood pressure? Increase of blood pressure. يبدأ cocaine, opposite to the other local anesthetic, produce increase in blood pressure. Others, they produce decrease. Why? Because they produce vasodilatation, as we will see later, and they will decrease blood pressure. Okay? The other, they produce tachycardia. Cocaine is known to produce tachycardia, increase the heart rate, لأن by inhibiting the reuptake of noradrenaline from the adrenergic nerve terminal, they increase the availability of noradrenaline at the adrenergic beta receptors in the heart, and this will produce tachycardia. Okay? So see, this is the second difference. A third difference, in cocaine is contraindicated in patient with hypertension. The other local anesthetic, they are not. ولكن cocaine is contraindicated in people who are suffering from hypertension or people who are suffering from ischemic heart disease. Why? لأن ischemic heart disease by increasing the heart rate will increase cocaine. By increasing the heart rate will increase the oxygen demand. The people already they have decrease in oxygen supply. In this case, what will happen? Ischemia will be more, and this is dangerous. So it is relatively contraindicated in hypertension or ischemic heart disease. طبعا the other local anesthetics other than cocaine, we can add adrenaline to them for certain reason as we will discuss later. لكن cocaine we never give adrenaline with cocaine لأن both of them they produce vasoconstriction and they might produce severe increase in blood pressure. But this is the difference. قلنا all the local anesthetics they share exactly qualitatively the same pharmacological action. Quantitatively they differ in only 3 actions اللي هم onset والduration والpotency. ولكن cocaine is different in terms of CNS stimulation, in terms of indirectly acting sympathomimetic activity, and in terms of use. Okay, so this is the difference. You have the local anesthetics, they produce certain pharmacological actions, as we have said. Most important therapeutic action is their block of conduction of sensation from the periphery towards the central nervous system. The other actions that are considered as toxicity or side effects. Toxicity or side effects. So what are the toxicities of local anesthetics? What are the toxicities of local anesthetics? So we will classify the toxicities of local anesthetic into 3 different types. The first is known as local toxicity. Then we'll talk about the systemic toxicity and a certain toxicity to a specific drug. Of course, the toxicity will vary according to the drug potency. The higher the potency of the general anesthetic, the more is the expected toxicity. Of course, the method of administration, it has a certain effect, and as well the adjuvants which are used with the local anesthetic. So the first is local effect, which results from the injection of the local anesthetic into certain tissue. And the first possibility is the possibility of neurotoxicity, which might take place due to intraneuronal injection of the local anesthetic. This neurotoxicity can be reduced by using specific guides to the injection, like an ultrasound, like an injection pressure monitoring, or nerve stimulation. A second possibility, if the local anesthetic is injected into a muscle, a skeletal muscle, this will produce skeletal muscle damage due to intramuscular injection. Usually this is a reversible and transient, and usually for recovery will take place after 2 weeks. Okay, these are the possible toxicities which can take place due to intraneuronal injection or due to direct injection into the muscle. Direct injection in the muscle, usually it is transient, and recovery will take place after 2 weeks. And other toxicities, the systemic effects, and the systemic effects results from the escape of the local anesthetic into the general circulation. And these systemic effects includes the central nervous system. Central nervous system, this is the most dangerous and the most sensitive to the effect of local anesthetic, and as well the cardiovascular system, which is less sensitive than the central nervous system. That means if toxicity on the central nervous system appears, this indicates that cardiovascular system toxicity will follow up. Okay, the central nervous system activity toxicity, once the local anesthetic escapes into the general circulation and reaches the central nervous system, especially the brain, this will result in disinhibition first. Or disinhibition, as we have discussed before several times, it means removal of inhibition. We said that the central nervous system activity, there is a balance between inhibitory and excitatory activity. Therefore, if we inhibit the inhibitory system, excitation will take place. This is known as excitatory phase. Excitatory phase. The excitatory phase of local anesthetic toxicity is due to disinhibition. Disinhibition means removal of inhibition. So excitation will take place. This is followed by general depression of the central nervous system, and this is known as inhibitory phase. This is known as inhibitory phase. Therefore, the CNS toxicity, there is excitatory phase and there is an inhibitory phase. Excitatory phase, usually there is signs of excitation. It starts with the symptoms of feeling lightheadedness, dizziness, visual disturbances, disorientation, tinnitus, and agitation. Then there is this toxicity might extend into shivering. The patient will become shivering, muscle twitching, tremor, and lastly, general tonic-clonic convulsion, which is the most dangerous. General tonic-clonic convulsion. طبعا in this case, if this happens, immediately it follows cardiovascular toxicity. Okay? يبقى the excitatory phase, the patient will feel lightheadedness, dizziness, visual disturbances, disorientation, tinnitus, and agitation. This might end up with generalized tonic-clonic convulsion in severe cases. After the tonic-clonic convulsion, the brain will enter into complete inhibitory phase, complete inhibition, and this complete inhibition will result in depression of respiration. And as we know, depression of the minute respiration will result in accumulation of carbon dioxide in the body. This is known as hypercapnia. Hypercapnia, increase in carbon dioxide in the blood, and this increase of carbon dioxide in the blood, of course, will result in decreasing the pH of the blood, which is known as respiratory acidosis. Respiratory acidosis. Once respiratory acidosis takes place, an intracellular pH will be decreased, and this will result in more ionization of the local anesthetic inside the cytoplasm. More ionization means more toxicity, more CNS toxicity. At the end of the inhibitory phase is complete respiratory arrest. Complete respiratory arrest. Of course, this takes place with the high dose of the local anesthetic, which can escape from the site of administration and can reach the central nervous system in high concentration. But this is the first systemic toxicity, which results from reaching the central nervous system. The beginning of it is excitation, which can end up with the tonic-clonic convulsion, and it ends up with the respiratory arrest. Usually, the central nervous system, as we have said, it is more sensitive to the local anesthetic than the cardiovascular system. The cardiovascular toxicity usually it has a direct effect on the cardiovascular system and indirect effect on the heart. So a direct effect on the heart, of course, they will block sodium channels in the heart. معناها they produce cardiac depression. They produce cardiac depression. In this case, the duration of action potential will be decreased and the refractory period will be decreased. As we know, this will result in different types of arrhythmia. They will increase the chance of arrhythmia. By the way, some of the local anesthetics like lidocaine can be used for treatment of certain types of ventricular arrhythmia. Like in the same time, in high dose and high enough dose, it can affect electrophysiology of the heart, and this can result in arrhythmia, i.e. they have anti-arrhythmic effect plus arrhythmic effect in high toxic doses. Okay? But this is direct effect on the heart. Of course, they will depress the SA node, this will result in bradycardia. As we have said, for cocaine, it produces tachycardia, and we have explained why. All the other local anesthetic, except for cocaine, they produce bradycardia. Why? Because they will depress SA node activity in the heart. وفي الأند it can, if this depression is strong enough, they can produce sinus arrest. Sinus arrest. Sinus arrest means complete cardiac block, complete cardiac arrest. Okay? Also, it will affect the blood vessel, producing vasodilatation, direct effect on blood vessel. Of course, the vasodilatation will result in hypotension. This is different from cocaine, which we have said produces vasoconstriction and increase of blood pressure. Okay? If the local anesthetic escapes into the general circulation and reaches the cardiovascular system, it can affect the heart directly and it can affect the blood vessels, decreasing blood pressure. Okay? We have to mention here that usually this toxicity is more with the racemic mixture, with the racemic potent local anesthetic. Why? Because the racemic potent local anesthetics like bupivacaine, it is non-selective. It can block sodium channels everywhere, including in urine and cardiac sodium channels. Okay, bupivacaine. But non-tumors like levoform, like levobupivacaine, it has no effect on the cardiac sodium channels. Therefore, it has no effect on the cardiovascular system. So, if somebody asks you which is the better effect on the cardiovascular system, levobupivacaine or bupivacaine, levobupivacaine is better. Why it has better cardiovascular profile? Because it is an antitumor. An antitumor means that it has a selective effect on the voltage-gated sodium channels on the neuron, and it has no effect on the sodium channels of the heart. Okay? Now, so this is the systemic toxicity. The ester group of the local anesthetics, they are metabolized to para-amino benzoic acid. Para-amino benzoic acid. And as we know, para-amino benzoic acid is allergic, as we have said for the sulfa drugs. Para-amino benzoic acid is allergic. It can produce certain types of allergic reaction, like allergic dermatitis, which is a skin rash. The skin becomes red, itchy, or sometimes it becomes scaly. Okay? يبدأ الإيستر group of local anesthetics, because they are metabolized to para-amino benzoic acid, they can produce allergic reactions. The most common allergic dermatitis, which is skin rash, red skin rash, which becomes itchy. Usually, no anaphylactic reaction takes place. The acute anaphylactic reaction is rare. It can take place, but it is very rare. Okay? يبدأ we have to make sure or we have to know in the Eastern local anesthetics, they can produce certain allergic reactions involving the skin. They can produce allergic dermatitis. Okay? Brelocaine, there is a possibility brelocaine, what does it produce? It will be oxidized to orthotolidine. Orthotolidine will oxidize the hemoglobin into methemoglobin, producing methemoglobinemia. And methemoglobinemia, as we have said, in this case, methemoglobin will not release the oxygen to the tissue, and this will result in tissue hypoxia. This can be treated with methylene blue. This is the only example of individual toxicity due to metabolism. Okay? Now, so these are the systemic toxicity of the local anesthetics. So the local anesthetics should produce certain action. We said should produce fast onset, should produce a long duration of action, and it should be potent enough to prevent transfer of pain from periphery to the central nervous system, i.e. they produce strong analgesia. Of course, there is no one local anesthetic which has all these good properties, so usually, sometimes, or most of the times, local anesthetics are given with other drugs. they are given with other drugs known as adjuvants to local anesthetics. Adjuvants to local anesthetics. What does it mean? Adjuvants means drugs which are given with local anesthetics. So these are used to increase the analgesia, increase the level of analgesia, to increase the duration, and to decrease the systemic toxicity. يبقى adjuvants to local anesthetics, drugs which are given with local anesthetics, they are used either to increase the level of analgesia before and after recovery from the surgery, to increase the duration of analgesia, and as well to decrease the systemic toxicity, This is done by different groups of drugs, including the opioids اللي هم morphine like drugs, المورفين like drugs like الفentanyl, morphine, diamorphine, fentanyl. These are the most commonly mixture which are used with local anesthetics, الأوبيويدز اللي هم المورفين like الفentanyl, morphine, diamorphine. We'll talk about the opioids inshallah in the futures in complete details. These drugs, they are used because the opioids, they are CNS depressant, so therefore they will decrease the dose of local anesthetic needed to produce strong analgesia. This is good. You have the opioids that are added to the local anesthetic to decrease the dose of local anesthesia. ما دام decrease the dose of local anesthesia معناها will decrease the systemic toxicity because we used a lower dose. Of course, morphine will produce a prolonged analgesia after recovery. This is good as well. يبقى المورفين like opioids to produce prolonged analgesia after recovery from anesthesia. These are two advantages. يبقى المورفين ولا opioids that are used to decrease the dose of local anesthesia and therefore will decrease the toxicity, and as well to prolong the analgesia after recovery. ولكن we have to take care of the dose. If we use high dose of the local anesthetic with the opioids, they can produce CNS toxicity. لأن الأوبيويد they are CNS depressant. With high dose of local anesthetic, they are CNS depressant in high dose. In this case, what will happen? Will potentiate each other, and this will result in dangerous CNS toxicity. Okay, يبقى الأوبيويds should be used with the recommended doses with local anesthetics. In this case, we reduce the dose needed of local anesthetics, and therefore we will decrease the systemic toxicity and will prolong the analgesia. ولكن if they are given in a high dose with the local anesthetic, they can increase the chance of CNS toxicity because both of them, they produce CNS depression. Okay? This is the first group. The second group are the alpha-2 agonists. The oldest was clonidine. This is the antihypertensive drug. Clonidine is not selective alpha-2. The most recent selective alpha-2 agonist is dexmedetomidine. We talked about it before with the general anesthetic. It is used as pre-anesthetic medication because of many advantages, including sedation, decreasing the dose of the general anesthetic needed, reducing stabilize cardiovascular function, plus analgesia after recovery. Dexmedetomidine is used as well with local anesthetic. Why? Because they will prolong the duration of sensory block, plus produce neuronal protection. It protects neurons due to damage of local anesthetic. ولكن these are two advantages. It prolong the duration of sensory block, معناها prolong analgesia. It produce neuronal protection. ولكن the problem with it, it can increase the chance of hypotension and bradycardia. It can increase the chance of hypotension and bradycardia. Okay? يبقى الالفا-2 agonist like dexmedetomidine is the drug of choice which is used with local anesthetic. It has many other advantages we have discussed before. The tail drugs Third group of drugs of commonly used with local anesthetic. The third group of adjuvants commonly used with local anesthetics are the vasoconstrictors. And the most famous example of vasoconstrictor is adrenaline. In some preparation, you might find noradrenaline, but mostly it is adrenaline. Adrenaline is usually it is added in a concentration of 1 gram per uh, per 100,000 milliliter, that means 0.01 milligram per milliliter, or 10 microgram per milliliter. يبدأ usually adrenaline in a dose of 10 microgram per milliliter of the local anesthetic, it is added to the local anesthetic as an adjuvant. Why? Because the adrenaline will produce local vasoconstriction. Therefore, by producing local vasoconstriction, it will prevent the absorption of the local anesthetic. معناها in this case, what will happen? The local anesthetic will stay at the site of administration. That means the duration of action will be increase the duration of action, and as well decrease the systemic toxicity. يبقى الادرينالين, it has two advantages. What does it do? Produce vasoconstriction. So what will happen? معناها it will stay at the site of administration. But then it stays at the site of administration for a longer period of time, معناها will increase the duration of action. Plus, as it is not absorbed, that means decrease the systemic toxicity. فالادرينالين is added for these two reasons: to increase the duration of action of the local anesthetic and to decrease the systemic toxicity. So adrenaline is used to prolong the duration of action, to decrease the systemic toxicity, so we can increase in maximum dose safely. But in this case, adrenaline is contraindicated or should be avoided in people suffering from hypertension or ischemic heart disease, because the adrenaline will cause vasoconstriction. It can increase the chance of severe increase in blood pressure, and on ischemic heart disease, it can decrease the oxygen supply to the cardiac muscle by producing vasoconstriction of the coronary artery. Okay? Now, if adrenaline is contraindicated, we can use another vasoconstrictor, which is philipressine. Philipressine is analog of vasopressin. It is a hormone, vasopressin, antidiuretic hormone. It produces local vasoconstriction. The philipressine is an analog or similar to vasopressin. Vasopressin is vasoconstrictor. This is the synthetic analog of it. Okay? Usually, philipressine is added in a dose of bond because it is hormone. It is expressed in international unit, 0.03 international unit per milliliter. Usually, it is mixed with brilucane. ولكن الفيليبريسين is not used in the North America like USA and Canada. It is commonly used in Europe and in Japan and in Asia. ولكن it's not used in the North America. Okay? الفيليبريسين, the same thing that is used. It can prolong the duration of action. It can decrease systemic toxicity, and it is indicated in people where adrenaline is contraindicated. Okay? So these are the drugs which are given with local anesthetics for three main purposes: to increase the analgesia, to increase the duration of action, and to decrease systemic toxicity. This includes three different groups of drugs: opioids, alpha-2 agonists, and vasoconstrictors. Okay? So next, we'll talk about the method of administration and the clinical uses of the local anesthetics, how they are given and in what conditions they are given. Okay? So local anesthetics are given by different methods, and these methods are classified into 6 methods according to the placement sites where the local anesthetic is injected or where the local anesthetic is administered. The first is the topical or surface anesthesia, as you will see. Second is the local infiltration anesthesia. Third is the peripheral nerve block. Fourth is the Bayer block or intravenous regional anesthesia. Fourth is the epidural anesthesia. Epidural anesthesia. Last is the spinal anesthesia or subarachnoid space anesthesia. Okay? As we can see here, this is, if we just imagine, this is the nerve trunk, main nerve trunk, which branches into nerve branches, and these nerve branches will end up with nerve ending. This is the nerve terminal. This is the nerve terminal, okay? If we anesthetize only the nerve terminal, this will produce local anesthesia. Local anesthesia of the peripheral nerve terminal can be achieved by surface or topical anesthesia and local infiltration. يبدأ في local infiltration and surface anesthesia we are anesthetizing a nerve terminal. Okay? If we anesthetize a nerve branch or the nerve main trunk, if we anesthetize this will produce regional anesthesia. Regional anesthesia including peripheral nerve block, Bayer block, epidural anesthesia, and the spinal anesthesia. Okay? The first two they are considered as local anesthetic, while all other four they are considered as regional anesthesia. Okay? The very first is surface or topical anesthesia. surface or topical ومن جاء اسمها السيرفس معناها we are spraying. It means we are spraying the local anesthetic into the body cavities or the skin, either on the skin or body cavities. They are formed from different formulation. They might be present as spray solutions, they might be present as creams, they must be present as gels, they must be present as solution, not spray, only solution, etc. Okay? يبدأ they are applied to the mucous membranes of the body, including the oral cavities, laryngeal, larynx, nasal, nose, vaginal, and the anus. يبدأ first they are applied to the mucous membrane of the body cavity, like oral, as you can see here. In dentistry, for example, before using the needle, they spray the place of injecting of the needle so that the patient does not feel the needle prick. Okay? So this is first. They apply it to the mucous membrane of oral, laryngeal, nasal, vaginal, and anus to produce local anesthesia at those sites. For example, for laryngeal, if they want to introduce laryngeal tube, in this case, they spray larynx with local anesthetic so that the patient does not feel the intubation. Okay? وهكذا. Also, they are applied to the skin external as spray ولا ointment. زي in cases of sunburn. لما واحد يتعرض إلى حروق الشمس sunburn. لما يقعد في الشمس لفترة طويلة ممكن جلده يحترق. يسموها sunburn. ولا في other minor burns. في حالات واحد يحرق صبعه ولا حاجة نتيجة whatever it is. كذلك it is used on the skin insect bites with stings. insect bites or sting. Okay? يبدأ this is used on the skin surface or topical anesthesia in a form of spray, creams or gels on the skin in cases of sunburn and in cases of minor burns ولا insect bites. Okay? Also, they are used in ophthalmology for the examination certain types of using instruments. In ophthalmology, they are used to anesthetize the outer cornea, to anesthetize the outer surface of the cornea. Okay? Yep, these are the surface of the topical anesthesia and its application. The most commonly used, all of them they are used. All of them. Lidocaine can be used, tetracaine, lidocaine, which is known as a very famous xylocaine, tetracaine, and benzocaine, dibucaine. Cocaine, of course, is different. Cocaine is still used in some ENT surgery, especially an ENT surgery of short duration, of short period of duration, because produce very strong local anesthesia with the least side effects. Okay, يبدأ this is surface topical anesthesia. Surface topical anesthesia. The second type of local anesthesia is the infiltration anesthesia. Infiltration anesthesia. When infiltration means direct injection of the local anesthetic into tissue to reach nerve terminal, to reach the nerve terminal. That means it produces local anesthesia. Usually, this is accomplished by addition of adrenaline or philipressine to prevent the spread of anesthesia and to prolong the duration of action. There are two different types. The first is the subcutaneous or intradermal infiltration, is the injection in subcutaneous tissue or intradermally. Usually, this is for superficial skin procedures. Superficial skin procedures, as in suturing of laceration or to take a sample from the skin and skin biopsies. Okay? يبدأ in this case the local anesthetic is injected in the subcutaneous tissue, or into the dermis near a nerve ending for very simple procedures like skin suturing of laceration, or when we want to take a biopsy from the skin. Okay? يبدأ this is the first. The second is made for a more extensive operation. In this case, the anesthetic is infiltrated into a muscle or into a fascia and other deep tissue. يبدأ this is infiltration, injection of the local anesthetic into a muscle near the nerve fibers or into fascia and other deep tissues for extensive operation. As you can see here in the surgical procedure, these are the point of injection into the muscle or points of injection into the fascia. Okay? يبدأ these are the infiltration anesthesia. Infiltration anesthesia will produce local anesthesia by anesthetizing the nerve endings of the tissue. It has a local effect. It can be done by subcutaneous or intradermal injection or infiltration into muscle or fascia. Okay? So this is the second type, which is infiltration anesthesia. What are the anesthetic used? There are different anesthetics used. Most famous lidocaine. It is used in a concentration of 0.5 to 2% alone. Well, maximum dose should not exceed 4 mg per kilogram of body weight. If we add adrenaline, we can increase the dose of lidocaine up to 7 mg per kilogram or a maximum dose of 300 mg. If we use bupivacaine, which is more potent than lidocaine, we use a lower concentration. The dose is a lower dose than lidocaine. It is, we said 3 to 4 times more potent, so we use a lower dose, and the maximum dose, as you can see, should not exceed 175 mg, whatever the body weight. Tetracaine, it's the same thing, 0.5%, dose 1.4 mg per kilogram, and the dose should not exceed 120 mg. Brocaine, ester, another ester, 1 to 2%, the dose is 7 mg per kilogram up to 600 mg per dose. You can see that the maximum dose varies according to the potency of the local anesthetic. The higher the potency of the local anesthetic, the lower is the dose used. Okay? So this is the second type, which is infiltration anesthesia, and it is used to anesthetize small part of the tissue. A third is known as nerve block anesthesia. Nerve block, in this case, we are injecting the local anesthetic near a nerve or nerve bundles, near a nerve bundle, near a specific nerve or a nerve bundles. This will produce what's known as regional anesthesia because all this region will be blocked. The sensation, suppose we're injecting in this area, in this case, all this region will be blocked, i.e., it produces regional anesthesia. Regional anesthesia. واضح الكلام؟ Okay. Usually to avoid intraneuronal injection and to avoid neuronal damage, this is done nerve block anesthesia. This is usually performed with the help of ultrasound or injection pressure monitoring. This is a specific instrument used to inject the local anesthetic, or by the use of nerve stimulation, which is rare nowadays, or fluoroscopy by using live X-ray or CT. The most commonly used is the ultrasound and the injection pressure monitoring. This is to avoid nerve injury, because if we inject the anesthetic intraneuronal, it can produce nerve damage. We should avoid that, okay, by these techniques. Usually, it is used for major surgery, including dental surgery, like a tooth extraction and so on. And also, it is used for the surgery of the upper and lower extremities of the arms and legs. You have the nerve block anesthesia can be used in dental surgery and surgery of the arms and legs. Also, it is used to treat certain types of acute pain for any reason, and for the diagnosis and treatment of chronic pain, as in cases of cancer. Okay, you have the nerve block anesthesia application too, and surgery of the extremities and oral surgery, and as well it is used to treat certain types of pain. Okay. Another use of nerve block, they are used as alternative to opioids in certain population and to produce anesthesia in certain population. For example, في حالة الهيد injury patient, usually opioids, they are contraindicated. In this case, we use the local anesthetic to produce analgesia instead of the opioids. وكذلك they are used either as a single dose to produce relief for hours, to relieve pain, acute pain for hours, and also they are used with the catheter. They are used or induced with a catheter. Why we use the catheter? To prolong duration, for months of relief, okay? Yep, they are used in surgery and they are used to treat pain. They are used to treat pain في حالات if we want a brief duration, we can inject a single dose. If we want a prolonged duration, we can deliver them through a specific catheter at the site of pain. Okay. The most commonly used is lidocaine 2% alone, with dose up to 4.5 milligram per kilogram. If we add adrenaline, we can increase the dose of lidocaine safely, as we have explained before. Okay. Now, bupivacaine, on the other hand, the same thing, 0.25 dose, 2.5 milligram per kilogram, lower than lidocaine, and with adrenaline, we can increase the dose up to 3 milligram per kilogram. نفس الشيء bupivacaine and different concentration, but the same dose. We can use ropivacaine, 0.2% dose, 3 milligram per kilogram, with or without adrenaline. Okay, so this is the nerve block anesthesia. They are used to perform certain surgery, dental surgery, or the lower and upper extremities. Also, they are used to treat certain types of pain. They can be used as single injection, or they can be used by delivering through a catheter for long duration of action. واضح الكلام؟ Okay. So this is the third type of local anesthetic, which are the nerve block anesthesia, which produces regional anesthesia. This is an example of nerve block in dentistry, where the injection is made in a nerve branch away from the nerve ending. If the local anesthetic is injected in this area, this will produce infiltration anesthesia. If it is injected far away from this area, it will produce nerve block anesthesia. As you can see, if we inject it in this side, all this area will be anesthetized. All this area will be anesthetized. The fourth type of local anesthetics is known as Bayer block. Bayer is the French scientist. Also, it is known as intravenous regional anesthesia. Intravenous regional anesthesia or intravenous regional shock. And from its name, that means the local anesthetic is delivered through a vein. Usually, this procedure involves the use of two cuffs, double cuff, one proximal cuff, this is a proximal cuff, and a distal cuff, proximal and distal cuff. Under certain pressure, this cuff will prevent circulation to the arm, In this case, the local anesthetic is given intravenously through a vein, and it will anesthetize the whole arm. These have many clinical applications, including surgical procedures of the upper arm and in certain cases of the lower extremities of the legs. Okay? This is used in surgery to prevent the pain sensation in surgical procedures in the upper arms and as well in lower extremities like legs, with less frequency. Also, they are used in the treatment of chronic pain associated with the complex regional pain syndrome. Sometimes this complex regional pain syndrome is a chronic pain which resulted from injury involving the arms or the legs, due to injury or due to surgery or due to stroke or whatever. This is chronic pain. Usually the patient will suffer from a chronic pain. In this case, they given the intravenous regional anesthesia to produce relief of pain in this area. Another use of the intravenous general anesthetics, they are used before giving botulinum toxin A in treatment of hyperhidrosis. What does it mean, hyperhidrosis? Hyperhidrosis means excessive sweating. They found that excessive sweating even in the arms, so they found that by giving botulinum toxin A, excessive sweating will be decreased in the arms. But botulinum toxin produce severe pain at the site of injection, so what they do, they give the local anesthetic first, then they give botulinum toxin, and botulinum toxin A will prevent hyperhidrosis for months. Another application of the local anesthetics, they are used for unidentified cause of pain. They are used as to produce prolonged analgesia together with guanidine and beryllium. Guanidine is adrenergic neuron blocker. Together, they found that by mixing local anesthetic with guanidine, they produce prolonged analgesia which can last for 5 days. This includes lidocaine and 2% concentration. With maximum volume injected should be between 12 and 15 milliliter of 2% solution. And this is the procedure which is used in North America, in USA and Canada. The others, they use as well ropivacaine and 3% with dose from 1.2 to 1.8 milligram per kilogram. So this is the fourth type, the Bayer block or intravenous regional anesthesia. The fifth type of the local anesthetics is known as the epidural anesthesia. With epidural anesthesia, the local anesthetic is injected in the epidural space, in the epidural space. This will produce anesthesia of all spinal nerve roots. All spinal nerve roots will be anesthetized. As we know, the spinal cord is covered by certain membranes that are known as spinal meninges. Spinal meninges. These spinal meninges includes three membranes. The outermost is the dura mater. This is the outermost, followed by the arachnoid mater, and the innermost is the pia mater, okay? So the outer one is the dura mater. Between the dura mater, the space between the dura mater and the vertebral wall, this space is known as epidural space. Okay? So let us zoom this to increase the size. So this is the dura mater, the outermost membrane of the spinal cord, and behind it, between the dura mater and the spinal walls or vertebral wall, is the epidural space. This is the epidural space, this space. So in this space, the local anesthetic is injected in the epidural space. This injection will result in the anesthesia of most of the spinal nerve roots. Okay? So epidural anesthesia can produce different levels of anesthesia. If it is used in small doses, it can produce sensory analgesia accompanied by minimal motor block. If it is used in high dose, it will produce dense anesthesia with full motor block. طبعا this is controlled by the drug itself, whether it is potent or less potent, but the concentration used and the dosage. Because we are injecting into the epidural stage, in this case, this preparation, the pharmaceutical preparation, contains no preservative. This kind of preparation, they are prepared without adding them any preservatives. Okay? Any drugs which are used in epidural anesthesia, they are free of any preservatives. So this applies the same to the spinal anesthesia, as we will see later. So what they are applied for? What's the application of epidural anesthesia? In many surgery, including cesarean section, including procedures of the uterus. You have the epidural general anesthesia. It has many applications, many surgery, including cesarean section, uterus, any procedures including the uterus, treatment of hernia, different types of hernia, genitourinary system, and lower extremities. Okay? Drugs used, they have different duration of action, from short duration of action, like chloroprocaine, or intermediate action, like lidocaine, like mepivacaine, or long-acting, like bupivacaine, etudocaine, and ropivacaine. These are the percentages used, the maximum doses, and the maximum doses in the presence of adrenaline. As you can see, we can increase the maximum dose by the addition of adrenaline, because adrenaline in this case will reduce local vasoconstriction, decreasing the absorption and distribution of the drug to the general circulation. Okay. This is the fourth type, which is epidural anesthesia. Lastly is the spinal anesthesia. With spinal anesthesia it is known as well as the subarachnoid block, or intrathecal block. Why it is known as subarachnoid block? Because the local anesthetic is injected in the subarachnoid space, which is the space between the pia mater and arachnoid mater, which is filled with the cerebrospinal fluid, of course. So this is usually spinal anesthesia. The local anesthetic is injected in the lumbar spine away from the spinal cord in the subarachnoid space. In the subarachnoid space. Well, the subarachnoid space, as I have said, it is between the pia mater and the arachnoid matter. This is the space, arachnoid, subarachnoid space. It is the space between the pia mater and the arachnoid matter. Pia mater and the arachnoid matter is known as subarachnoid space. Okay? Of course, the injection of the local anesthetic in subarachnoid space will produce anesthesia of the spinal nerve roots and the dorsal ganglia as well. This will result in the anesthesia of the sympathetic nervous system, sensory afferent nerves, and as well motor nerves. Okay? This spinal anesthesia is used or indicated for major surgery involving lower part of the body وكذلك as well الupper abdomen والlower abdomen وكذلك it is used in obstetrics في vaginal delivery ولا cesarean section, and as well it is used in diagnosis in painful diagnostic procedures وكذلك therapeutic procedures below the diaphragm. Most commonly used as spinal anesthesia are hyperbaric bupivacaine 0.5%, or the use levobupivacaine. It is very popular because levobupivacaine, if it is absorbed, it has no effect or negative effect on cardiovascular system. Other choices including hyperbaric prilocaine 2%, or the use of plain 2-chlorobrocaine 1%. So the spinal anesthesia is the injection of the local anesthetic in subarachnoid space, and this will produce loss of sensation of all sensory input, and as well as sympathetic block and motor block. واضح? Okay? Now, so all this is about local anesthetic. So, in summary, I summarize what I have talked about in this long lecture. Excuse me for the length of the lecture because I want to give the whole subject in one shot. As I have said, they are either ester or amide. They are present in two forms, non-ionized, and this is necessary to cross the biological membrane, and the ionized part, which is necessary to block the sodium channels. The degree of ionization, we have said, depends on the pKa value of the drug and the pH of the environment, where the lower the pKa, the faster the onset, and the lower the pH, the more potent is the anesthetic. We said that except for cocaine, all of them, they have similar qualitative property, but they differ quantitatively in three properties اللي هم onset, duration, and potency. They have similar toxicity except for cocaine. I repeat that all of them, they share the same toxicity. Well, this toxicity will depend on potency, as I said, method of administration, and concentration used. Either the toxicity is local due to wrong local injection into the neuron or the skeletal muscle, or they can produce systemic toxicity, including the cardiovascular system and the central nervous system. The central nervous system first is more sensitive, and then followed by the cardiovascular system. When they produce dose-dependent local anesthesia, this depends on concentration, the doses, and method of administration. They are used either locally as surface anesthesia or by infiltration, and this will produce local anesthesia, or they are used by injection near a nerve block, or they are injected in the epidural space or subarachnoid space to produce what's known as regional anesthesia. At the end, I will say, لله الحمد من قبل ومن بعد. I would like to thank you to stay with me till the end of this presentation. I hope to see you again in my next presentation, which will be about sedative hypnotics and anxiolytics. شكرا لكم على حسن الاستماع. الرجاء لا تنسوا الاشتراك في القناة، الإعجاب، التعليق، والمشاركة مع الزملاء. دمتم بخير وعافية، والسلام عليكم ورحمة الله.